I'm based at Liverpool. I'm a clinical academic, and like many of the centres that you work for, largely sort of see a lot of the pathology related to thrombosis and haemostasis. I also have a link to the Liverpool Tropical School of Medicine, and that's been a very useful thing for us as we've kind of developed our interest in all things relevant to thrombosis and haemostasis. So in clinical terms, the pathology that we see, very, very similar to what you see. At one end of the spectrum, the bleeding disorders and haemophilia in particular. At the other end of the spectrum, thrombotic disease. And we are an accredited UKHCDO, European Comprehensive Care Centre. And from a thrombosis point of view, you can imagine the sort of complex pathology that would exist in Liverpool, and we're also the major northern centre for TTP, taking patients from as far as Manchester and Derby. Perhaps slightly uniquely for us in Liverpool is that we probably span a little bit in between as well, where we take a very active interest when things are a little bit complicated and when bleeding and thrombotic events can sometimes occur simultaneously in the same patient, and that's usually because they have caught nasty infections or are very ill in the intensive care setting. So that's the kind of breadth and depth of the work that I've been involved in, and I will share some aspects of you in describing what is out there that might interest you in thrombosis and haemostasis. So it's the typical kind of things that one goes through when you give a talk, and I'll try and make sure that the very relevance of why you should be interested in thrombosis and haemostasis research is clear. So why is it important? It's very basic and very simple. It's central to good health, central to medicine, that we maintain good blood flow, good vascular integrity. So in all diseases, in all organ-specific diseases, blood is important, and we are central to it. And of course, the vast endothelium. If you could spread it all out, somebody sort of calculated that the surface area is equivalent to the size of a football pitch. So many things can go wrong, and many things indeed do go wrong. But the research in this area has been very productive, and we have transformed lives, we have saved lives. Haemophilia is a classic example. Now, haemophilia care these days is fantastic. And the slide on the left, I'm not sure if you can read it, but it's a picture of Alex Dowsett, who has severe haemophilia A, who competed in the Tour de France. So who would have imagined that 50 years ago? But this is what the science and research in thrombosis haemostasis is doing, all right? Transforming lives. And of course, on the right-hand side, we don't claim the highlight, our stroke physicians do, but it is our drugs, the oral anticoagulants that are making a difference and are very important to keeping people well. And not just those two examples. In TTP, on your left-hand side, there is a lot left to do. But even the evidence in making sure that people get plasma exchange very quickly and very acutely has changed our survival rate even for our patients in the Northwest. When we started this, taking on board these patients, I think our mortality rate was about 50%. And now our survival rate is 100%. So touch wood, things can continue to improve. And we heard very much about tranexamic acid and how, again, in a condition that perhaps is slightly peripheral to hematology, we are making a difference. So it gives me confidence, and of course I would say this, but I do believe that I have the basic understanding to claim this, that by exploring mechanisms in thrombosis and haemostasis, we are in a good position to address areas of unmet need. And for me personally, one of those areas is in sepsis. I like to think that we will continue to make progress from a from the prism of thrombosis and hemostasis. So, why is it so important? Why is thrombosis and hemostasis relevant? And I think the simple answer is that it's important in evolutionary terms. So the ability to form a clot to stop us bleeding to death may not be so relevant now, but in the not too distant past was crucial to survival. So that's evolved as we've evolved, and that's sort of become more sophisticated, and of course many other processes are involved. So the very key to forming a proper, exquisitely formed clot is the pivotal role of thrombin generation. So most of you will know this. I'm sort of teaching you nothing that is entirely new. But upon injury, the two pathways, intrinsic, extrinsic, sort of are activated and coalesce, converge, and it leads to that important generation of thrombin. I position it in the middle because clearly it grabs fibrinogen, which is in large amounts in the circulation, and clips it into fibrin so that clot is formed quickly. But it's also the architect of its own demise by activating the protein C pathway, APC, activated protein C, for short, feeds back in a kind of negative feedback loop kind of way, slows down thrombin generation. That in turn shuts down fibrin conversion, and the whole thing comes to a slow halt, and you get this fine, nicely contained clot that does its job. Now, in the area of my interest, which is DIC, if thrombin generation is in excess and sustained, you see depletion of the procoagulant factors that can then lead on to a bleeding tendency, but equally depletion of the anticoagulant factors that can predispose to vascular site-specific thrombosis. But I think this sort of simple sketch of thrombin generation has relevance because we know that the two key areas where it's made an impact on patient care is targeting coagulation at the 10A level and targeting it at the thrombin level. So historically, of course, you have unfractionated heparin. Now, of course, the bigger trend is working at that level, and at the 10A level, it is quite clear that these are important critical steps for informing us, but also in helping our patients. Likewise, this paradigm of thrombin generation that I've sketched is relevant to how we understand problems in trauma. So if you imagine this excessive amount of thrombin generation when somebody is bleeding massively, what they're trying to do is to form as much fibrin as possible. So at the same time, because of the protein C pathway, you will also see a rise in the level of APC. And some people have thought that, well, maybe it's the APC that's contributing to the increased bleeding. Clearly, it is not. The amount of APC that's generated is in sort of nanogram per ml doses. It doesn't contribute that significantly. It's sort of associated because the driver is towards procoagulant fibrin formation. And of course, thrombin is well known to cause the release of TPA from endothelial cells. And this whole fibrinolytic process is going to overdrive. Clot is being formed, but clot is being lysed quickly. And the only way to deal with it is to block that fibrinolysis. And we know, as we've heard, that tranexamic acid, cheap drug, saves lots and lots of lives. So this is only one example of the many ways in which we can tell our colleague physicians how important thrombosis and hemostasis is. And thrombin is, of course, ubiquitous as well in the inflammatory pathway. Not only is it important in the yin and yang of balancing clot formation, but in also maintaining endothelial integrity, so that the balance between pro and anti-inflammatory pathways that are key to cell survival. So, from a research point of view, if you are starting in your career as a hematologist and have an interest, there are many dimensions of where you can look at. whether it's fibrinogen or fibrin or something else or protein C. You're not spoiled for choice. I'm just going to run through a couple of things that I think are still areas where questions need to be asked and where perhaps there are some UK strengths and where you might consider wanting to explore, to develop perhaps more research interest in this area. So acquired haemophilia is a major issue. Still not perfect, still a lot of things that we could do better. And Amit Nathwani's group at UCL and the Royal Free are really quite major leaders in the kind of gene therapy world. And there's a lot of work now, particularly in personalizing how haemophilia care should be delivered. So from a platelet perspective, Willem Ouwehand's group has sort of almost revolutionized the kind of genetic detection and identification of defects. Steve Watson's group in Birmingham are major leaders in understanding platelet receptors, platelet function. In the world of thrombosis, there's many things still to understand the relevance of the endothelial wall. Beverly and her group have, of course, been doing a lot of work on APS, and there's still perhaps room for emerging anticoagulants. So from the thrombotic microangiopathy point of view, you will hear from Marie Scully tomorrow, and clearly she's been pivotal in making good care available to patients around the country, and Jim Crawley's work on Adams with David Lane has also been important. And what I mean by stratified medicine is probably in the next decade or so, we will better understand which spectrum of that thrombotic microangiopathy it is, whether it's clearly TTP or AHAS or somewhere in between. So from my own personal interest point of view, we like to think that we're doing interesting things. Endothelial recalibration, particularly around malaria, but probably also in sepsis, is important. NETS is a burgeoning field. If you don't know what NETS stands for, you really must go away from this meeting understanding it, because it is an explosive area at the moment. It stands for neutrophil extracellular traps. And DAMS stands for damage-associated molecular pattern proteins, including histones. And histones are a very good example of the kind of yin and yang balance in healthcare. So if you're still interested in research after hearing all this, which kind of research? Because again, all of us want to do something that we think can help the patient, all right? Help their quality of life, help their survival. And this is a kind of a rough sort of idea what types of research studies you can do. On the left-hand side, it's basically the discovery science, molecular discovery, more bench work. And to the right-hand side is, of course, more clinical trials and the consequences of clinical trials in taking forward this kind of really from bedside to bench, but also back to bedside pathway. And actually, we hematologists are naturally inclined to do that. We hematologists choose this career because we like that. So I think intuitively, we are actually very good at doing this kind of research. So I'll give you some examples, and I choose things that I know a little bit about. The translational gap 1, more discovery size. And this is work on histones. Now, histones are very important in the nucleus because it helps the cell work well. But actually, when it's released outside the cell, it's very cruel. All right? It basically damages a lot of things. So the kind of science you need to show, really, these days is a combination of in vitro bench work, in vivo work, where you model with animals, and ideally also to then see if it translates to patient. And in this setting, we've been able to take samples from patients, for example, with trauma or sepsis, and demonstrate that if you incubate their plasma, very simple experiment, incubate their plasma with some endothelial cells, and then the endothelial cells will die, and you quantify that. we can show that their serum or plasma will cause cell death, and if we block the histones with an antibody, that those cells are quite happy. So is that kind of work that you would be considering? In terms of translational gap 2, this is about randomized clinical trials. And I think operationally it needs much more sort of a collaborative effort. And we could do this because it combines our strengths in anticoagulation, but also in Liverpool we have the MRC hub for trials methodology, and also somebody who's very interested in pharmacogenetics. So I say this because sometimes you need others, and I think the message from this meeting should be talk to people. You never know what might come out of it. At worst, nothing, but you know, it might be something. So where can you do this? I was expecting Beverly to have covered this, but actually I think this is very easy to find. The major funders are MRC and the National Institute for Health Research, NIHR, and then of course there are charities like Wellcome Trust, British Heart Foundation is also relevant to thrombosis and haemostasis. And whilst one would like to think that you know, it sometimes needs a little bit of hard work to get these kind of funding, especially if, you know, at an early stage in your career, especially in getting fellowships. Nonetheless, we should be thankful because despite the austerity, the money for healthcare research is relatively well protected. And it is because the likes of Sally Davis have been very clever in arguing that the health and wealth agenda are very tightly coupled together. So it's partly about inviting big pharma and other industries to come and do business in the NHS, but also the NHS is a great place for recruitment, but also the potential for new diagnostics, new therapeutics, all bring wealth to this country. So there's a clear structure, and you can Google all these things. Ideally, when you're born, you should know that you want to do research in thrombosis haemostasis. Then it becomes very easy. But if you're year one, you know, SPR, and you are interested, talk to relevant people, and there are pathways that can get you through the right stage. But even if you don't get on those structures at the right time, at the right place, there are ways of getting around it. So don't despair. Because the research pathways, up to now I've only told you about the kind of discovery science and the clinical trials, goes beyond that. Because you do have to take research that is showing benefit from trials into adoption, and then from adoption into, you know, widespread use. So there's always a need for clinicians to recruit patients, for clinicians to enrich the evidence because of the real-time, you know, practical use of these products. So there are refinements to that research pathway that everyone can contribute to. So don't at any point feel disillusioned that all the things I'm talking about are beyond you. It is not. And the reason is there is a good infrastructure now. It is called the NIHR Clinical Research Network. Probably most of you have heard a bit about it, but I'll hopefully try and give you a bit more information. So it's set up throughout England mainly, but there are similar structures in the devolved nations. And there are 15, I think, sort of regional kind of branches. And basically, they have to make sure that any clinical trial, whether commercial or non-commercial, is delivered to time and target. So for example, you know, big pharma comes knocking on your door and say, we want 1,000 patients to be recruited in the UK. Can you do this? And the network goes around, searches for sites, and goes back to them and say, yes, we can, etc., etc. And this is where you can do it. So at each of these colors, each of these patches, there's a lead for hematology. And their task is to make sure that all the trials on their portfolio are managed properly. So, why is this so important? I think I've, of course, mentioned a little bit earlier, but the added value, not just to patient benefit, because we all know that participation in research actually improves the outcome. You know, politicians are, of course, happy with that, but the real thing is the money sign. Involvement in research, whether it's through pharma, et cetera, has economic impact. So the estimated gross value added figure is 2.4 billion, all right? I'm not inventing this. This is from figures that are widely publicized, and Sally Davis always keeps shouting about this. And of course, the number of jobs that it creates. So it's an industry, and you should take advantage of it, all right? You know, you are in it anyway, so take advantage of it. Because ultimately, you are in this profession to do good. And if it's through research, whether it's the discovery science or whether it's delivering it, it doesn't really matter, so long as you are involved. So how can you get involved, and who do you need to see? And I think the answer is that you need to be in touch with the CRN, and I'll put those numbers up. But for the trainees in this room, this is actually a good time to be talking to you, because NIHR CRN in hematology, for their objective for this year, 2016, and for 2017, is to develop a trainee in each region to be a champion for research. So that means we have somebody who will help the clinical lead and try and recruit more patients, get something into their CV, hopefully sort of gain the understanding of what it takes to deliver research, and hopefully helps them when they go for their consultant job interview. So we've recruited some, but we have a way to go. So if you are interested, come and see me, all right? But you can find out who the leads are anyway by Googling NIHR CRN. But the key thing is, my address, very simple. There's only one toe in Liverpool. Right? And it's actually not true, but you'll find me. But Michael is kind of on the committee and is kind of pushing things from a trainee point of view. So I'm around today, I'm around tomorrow, so don't hesitate to talk to me. Don't hesitate to talk to anybody else. If you need an introduction to somebody, you know, we're always happy to facilitate. So that's all I have to say. Thanks.